So focusing on the right patient and right lesion selection for the BRS. We've been listening for last 1.5 hours about which is basically the theme is very much clear by the previous presentations, but I will quickly take you through a few of my cases which will give a clear message to everyone. So straight to the cases. Case 1 is a 44 years old male. He's been hypertensive for last 4 years, non-diabetic, non-smoker. He presented with acute coronary syndrome, and the ECG revealed inferior retrieval inversion in the 2-3 AVF, and on echo there was NFUL hypokinesia. EF was well preserved, 50%. And on the basis of this clinical scenario, young patient, ACS, NFUL hypokinesia, fairly preserved LV function, and the diagnostic angiography revealed a discrete lesion. There's a 99% thrombotic lesion in the distal RCA just before the crux. And the PD PRV a good size, and it's filling from the left system also. So this is a very ideal case. Young patient, ACS, with a discrete lesion. Now this is about the procedure. They crossed with the run-through wire, and then making space for the this OCT, because you need some space for the dye to flush off while doing a OCT. So the little bit of dilatation with a 2 mm balloon, and then the OCT ran. You can see the lesion site. It's a little bit of fibrosis, and the thrombus is clearly visible. And it's a discrete lesion, thrombotic, and with a little bit of fibrosis. So this is the ideal case. Then this is a lesion preparation. As we discussed, we need to dilate it well. So I frequently use a scoring balloon for that, the 315 balloon, as the lesion was fibrotic, and it was dilated to 16 to 18 atmosphere. And subsequently 3.5 to 29 millimeter BRS medicine did was positioned across the lesion, covering the whole length, distal as well as middle plaque, and then slowly deployed to 9 atmosphere. And subsequently post-dilated with 3.5 millimeter NC balloon at high pressures, 24 to 28 atmosphere, and the lesion was quite good on OCT. This is the OCT pullback. You can see they are nicely embedded studs and a very good luminal gain and well-opposed studs. This is about the first case, and the angiography picture look quite pristine, and he has completed 6 months follow-up. So this case was approached with meticulous lesion preparation by scoring balloon, and the sizing by the OCT, and the post-dilated high atmosphere, and very well optimized. He's doing quite well. Case 2 is a 73 years old female who's been hypertensive for 6 years, non-diabetic, and is a known case of CAD with the history of PCI to RCA, proximal mid long stent, in June 2020. And at the gap of 1 year and 3 months, she presented with ACS. Enzymes were a little bit elevated, and the LV was quite well preserved. 45 to 50% ejection fraction, inferior hypokinesia, STT changes in inferior leads, and angiography was performed, which revealed 99% ISR in the RCA stent. And LAD was having a 60 to 70% tubular lesion in the proximal mid segment. You can see the LAD is borderline 6 to 70, and there is a clear-cut 99% CA stent. This is also one of the, I can say, the ideal indication when you don't want to have a 2-layer of metallic studs. So we can place the BRS in that scenario if the balloon result is not quite good. So in instant restenosis, just to avoid the one more layer of metallic stent, if the result with the balloon dilatation is optimal, you can do a DEB, dilating balloon, but if there is a suboptimal result, then you can go for the BRS, which is ideal because it will go away over 2 to 3 years time. And then nothing is left behind. So initially, again, as a 1.5 10 meter balloon, because the region was quite tight, and the 3 millimeter balloon was not going across. So it's a 1.5, then 3 millimeter angioscope scoring balloon. And at high pressures, 24 to 28 atmosphere, we dilated with the scoring balloon. to get the good luminal gain and prior to BRS. And this is the OCT pullback.
Did you dilate the stent with the balloon which comes with the stent?
No, I do dilate with the which comes with that, but frequently I use scoring balloon if there is a fibrosis, and because in this particular case this is an intimal because it's 1 year and 3 months, 4 months, so I could see the intimal hyperplasia, some fibrosis. So just to prepare the bed well, I had used a scoring balloon 3 millimeter and went up to 26 to 24, 26 to 28 atmosphere.
So for post-dilatation, do you use the balloon which comes with the stent?
Yeah, comes with the stent, yeah, post-dilatation. And this is the 3x40 BRS position across the lesion, as well as covering most of the length of the previous stent, although the little small length left in the distal part. And this was deployed slowly, 8 to 9 atmosphere. And then there is a post-dilatation initially with a 3 millimeter because balloon was not going across, a 3 millimeter balloon, and then subsequently 3.25 NC balloon at high pressures, 24 to 26 atmosphere. And this is the OCT pullback. We can see there is a BVS struts visible, well deployed. Very well opposed inside the previous stent. So this was the angiographic picture following the OCT pullback. It's a very well deployed BRS, the 340, and then it gone with the 3.25 and 3.5 NC balloon at high pressures. So again, this is a meticulous lesion preparation followed by sizing and also the good post-dilatation at high pressures. And this patient is also completed 5 months of follow-up, and she's been doing well. The third case is a young 32 years old male who's a non-diabetic, non-hypertensive, non-smoker, but he had a history of PCI in 2014 when he was almost 28 years old, quite a young patient. And he presented with the ACS, like a chest pain of 1 hour duration, to a local hospital, and there was a ST elevation there, and they thrombolized with the streptokinase, and subsequently patient came to us for the further evaluation. And hemodynamics were relatively stable. EF was fairly well preserved. It's around, you can see it's around 40%, and LAD territory was hypokinetic. You can see there is a stent in the proximal to mid LAD, and there was an under expansion of the mid LAD stent, and there was a thrombus at the distal edge. We did OCT pullback, and then thrombosuction was done initially. Post thrombosuction, we can see there is an under expansion of the previous stent, which was placed outside the hospital, and also there is a thrombus beyond the distal edge of the stent. And there's a lesion with a severity of around 60 to 70%, and did the OCT pullback. And OCT revealed this instant hyperplasia and the borderline severity of the lesion around 50-60%. Here it's a little tight, around 60-70, and there's a branch coming from it, and there was a thrombus beyond the distal edge. Now this is the pre-PCI OCT. It was a borderline lesion and with a thrombus. Again, only the NC balloon for the pre-dilatation, 3.5 millimeter balloon at 26 to 28 atmosphere. And after adequate pre-dilatation, 3.5 to 32 BRS was positioned, covering the whole length of the previous stent. and it was deployed at 9 atmosphere slowly. And then post-dilatation initially with 3.5 NC, 28 to 30 atmosphere, and then with a 4 millimeter NC at 16 to 18 atmosphere in the proximal part of the scaffold. And this is the OCT imaging. Here you can see the BRS struts visible. There is eccentric expansion in the proximal segment, where he had a neoatherosclerosis by the previous stent, but good luminal gain and fairly well opposed BRS struts. This is the snapshot of the post ECI OCT. So good luminal gain and fairly well opposed struts. This is angiographic picture in ariocaudal and also in the cranial view. So well deployed BRS, and this is ideal. They're 32 years old with a previous PCI, and we don't want 2 layer of metallic stand. So BRS is ideal choice in such a scenario. And this patient has completed 11 months of follow-up and has been doing well. The fourth and last case is 63 years old male who's a hypertensive, non-diabetic and non-smoker. He presented with a history of a recent antiviral MI February last year, and he was thrombolyzed with streptokinase and came to our hospital for further evaluation and treatment. Hemodynamics were relatively stable. Here your lab reports are okay, and ECG, the serial changes of antiviral MI on echo EF was 30%, RWMI in LAD territory, and here is the angiographic picture. There was a eccentric lesion in the proximal AD, 90-95% thrombotic. RCA was normal, and circumflex also disease-free. This is again a discrete lesion in the proximal AD with the ACS presentation. It's also an ideal indication for the BRS. Initial dilatation with the 2.5-15 balloon, and then with the NC balloon is a part of pre-dilatation. 3.5 millimeter NC balloon at high pressure, 20 to 24 atmosphere. Just for the adequate preparation of the bed prior to BRS, and then 3.5 to 32 BRS across proximal to the mid-AD, covering the whole length of the lesion, and slowly deployed at the 9 atmosphere as has been recommended by the manual, and then post-dilated initially with 3.5 NC at a 20-24 atmosphere, then with the 4 millimeter NC at 40 to 16 atmosphere. Then is a post ECI OCT. And now we start seeing the BRS struts, very well opposed, well embedded struts, and good, nicely opened a vessel, good luminal gain, and at some places there a little bit of plaque prolapse. Result was quite good, and edges were healthy. There was no edge dissection or a little bit of plaque prolapse here and there. So this is the final snapshot. Good luminal gain, well deployed BRS, and very nicely embedded struts. So this is the final angiographic picture. The proximal to mid-AD, this 3.5 millimeter BRS, and his LV improved on the first follow-up. Within a span of 30 days, his LV ejection fraction improved from 30 to 45%, and he has also completed 11 months of follow-up and has been doing well. So to conclude, in a carefully selected patients, BRS has a definite place on the basis of the great 3-year data, what we have. And the young patient, acute coronary syndrome presentation, and the instant restenosis are the few preferred indications in which we can expect a very good result. And the meticulous lesion preparation is the bottom line. We have to take care of the lesion preparation prior to going for the BRS deployment. And the imaging really helps in optimizing the scaffold deployment, and it's a very important. And we need we need a OCT imaging, and any imaging. If OCT is not available, we can use the IOS also. So image-guided optimization is needed to achieve the best results. Thank you.